course, yes. So welcome up, Leslie.
I'm really impressed with Delonte and his mom for being able to get up here and talk about their journey and the hurdles that they've gone through. We're going to totally shift gears and try to cram a whole lot about research and the brain into this next topic, before the break. So I'm here today to talk about neuropsychology, the brain, and schizophrenia. More so a review than a deep dive. I have no disclosures. The biggest disclosure, can you all hear me? Because the mic is kind of back here. No? Is that better? It's kind of like back here on the back of my shirt, so. How about now? Okay. I saw Claire back there squinting to hear me, so I'm glad I asked. My other disclosure is that I'm not a nationally recognized expert in schizophrenia. While I've taught graduate level courses about the neural underpinnings and what we know so far, I'm not an expert. Additionally, as a neuropsychologist, I don't treat this really difficult disorder, more so do evaluations of patients who may have it. Even though this is a small portion of the patients that I see, as you can imagine, it's some of the most memorable and some of the ones that have had the most impact on my career in the past 14 years here. Toward the end of the presentation, I'll give you a few case examples. So some of you will be quite bored. I know you hated neuroanatomy. Unlike me, it's my passion. Give me all the brains. We'll talk about the neurodevelopmental model of schizophrenia, which is really where the field is moving, right? We need to figure this out before it gets to the point where it's chaos and where we have a harder time intervening. What can we do earlier? And then we're going to understand some of the cognitive dysfunction through case studies. So one of the ongoing puzzles of schizophrenia and serious mental illness is, why does it happen, right? One of the greatest things that we've really been looking into is the brain. As Dr. Cutler mentioned, what is going on in the brain when this occurs? So there's been many studies, and this is still a little controversial, and depending on what research you look at, we'll say that this happens or this doesn't. But one thing that I'm most interested in is the idea of neural pruning. So as you guys know, the slide on the right, these are just images of what the synapses look like in our brain. When we're born, we don't have many synapses at all. And then from birth until about 6 years old, we have a whole lot of massive neuronal growth, right? We're learning to walk, talk, we're taking everything in and developing those connections in the brain. So really what we like to call neural coupling, but we're not going to get into that. This could be a whole lecture in and of itself. And then after about 6 years old, you can see how many synapses are in the brain and how much it's taking to get those things together. So then into those teenage years, we start to have neural pruning, right? So in the teenage years is when that frontal executive system comes online and the connections we make, our brain is trying to reduce and make more efficient. So you can do things faster. Instead of just walking, you can now skip and jump, things like that. One of the hypotheses is that from 6 years old to 14, in patients who later end up being diagnosed with schizophrenia, is that the process of neural pruning isn't working right. Either there's too much pruning, the wrong couplings going on, and we'll get to some genetics about this in a little bit that I know Dr. Sanders at the back is probably excited to hear about. But this is really where we're hoping to go and where a lot of the animal models are looking. So I know we saw where we're at now, and I'm taking a step back more towards the research of what do we need to be looking at, what can we maybe change so that the inner neurons of people with schizophrenia look more like the healthy controls going into adolescence and young adulthood when the disease process really comes out. Neuroimaging. So the thing Ramon didn't say is before I became a clinical neuropsychologist, I was going to be a researcher looking at biomarkers for Alzheimer's disease. I was doing a whole bunch of fMRI data. Got really boring, right? I wasn't seeing any patients. I was just sitting behind the computer crunching all the numbers. So this is kind of a passion of mine and Dr. Geary over there. That's why we wear these glasses, all the brain tracings, things like that. But for patients with schizophrenia, there's a lot of research showing what is going on in the brain and that there are changes, which is why then outwardly you're seeing disorganized thought. You're seeing trouble taking in questions and processing what people are asking and what you need to respond. Delonte did a fabulous job, but as you could tell, especially in the beginning, knowing where to start, what to ask, what to talk about was challenging because of these brain changes. So the top study, I'm just going to breeze through this real quickly. Feel free to jump in and ask questions, but I don't want to spend too much time on this because I want to be able to get to our case studies. So the top study looks at healthy controls compared to patients with schizophrenia, breaking out boys and girls. And it's showing really that, there are changes in fMRI in age-matched peers, and that most people would think that patients with schizophrenia would show a reduced, bold oxygenated response, right? Their brain isn't working as fast, it's slow. No, we see the other thing. They're actually working exceedingly hard. Their brain is firing so much to try to figure out what to do with all this information that's coming at them, which is why you see the differentiation, activation in the patients with schizophrenia in the frontal parts of their brains. So they're actually working so much harder to accomplish the same task that we're all accomplishing, right? Even starting out like, tell us your name, tell us your diagnosis. It's like, I don't know where to start. Basic brain MRI studies, you guys probably all know this, but we know that there's an abnormal loss of gray matter, usually around adolescence, in patients who later on develop schizophrenia. So we can even start to see these changes in the brain before they're diagnosed. So are there other things that we could be doing earlier on to implement and maybe prevent things down the road? The bottom studies are actually really cool. We'll kind of talk about this in a minute. So for years, we didn't really have ways of measuring synapses in the brain. And this is a really cool study by Howes and Unwardy, just published last year in Nature Communications. So what they did is in living brains for the first time, they looked at how are synapses working. So they developed a tracer through PET scans that could actually pick up SV2A, which is a glycoprotein that we know is involved with synapses from animal models. And it's only 18 patients with schizophrenia and 18 healthy controls. But what they found, and you can see in the color differences, right, that the people with schizophrenia have lower levels of synaptic markers when doing the same tasks in the frontal parts of their brains compared to healthy controls. So this is where the field is moving in terms of looking at neural connectivity, synaptic pruning, synaptic connections, as well as lots of DTI studies trying to figure out what is going on with these connections in the brain. Since most of you are not neuroimaging researchers, we're not going to spend all the time on this. Don't worry, we'll move on from that. But there are hundreds of studies looking at this, and takeaway is that there are changes that are detectable. We just don't have enough data to use it clinically at this point. And most of the time when these are being detected, you're not going to be seeing the outward symptoms. Out of all that research, there's one neural network that I wanted to focus on today, because I think this is where the field is going in terms of figuring out things a little bit earlier. So as you guys know, a part of schizophrenia, I'm not going to go through the DSM, is the negative symptoms, one of which is amotivation. So we know that this amotivation circuit, rather than discrete brain regions, is impacted in patients with schizophrenia. And importantly, in a lot of studies, motivation, ability to engage, is one of the moderating factors in functional changes in schizophrenia. I was really impressed with Delonte saying, I go on walks, I make these bracelets. Wow, like he is actually doing the things that we know are helpful, but is so hard most of the time for patients with schizophrenia to get started on. You probably don't care about the brain regions, but really think about that kind of orbital frontal cortex, the bilateral ventral striatum going back, and then the dorsal anterior cingulate cortex are the ones that you should be thinking about and reading about in the literature coming forward. So since I'm a neuropsychologist, I like data and measurement of brain functions. So this is a really, really interesting study by Needham et al. That incorporates neuropsychological testing and abilities. So what this study did is it's actually a really large prospective study from that National Collaborative Perinatal Project. So there is a sample of over 9,000 kids who had gone through lots of different testing, things like that along the way. And all of them are tested every year. And this is a cohort of people who were tested at age 7 on what we call the WISC, the Wechsler Intelligence Scale for children. And what this study did is they looked back at pulling out from those 9,000 people, how many of these kids developed schizophrenia? Out of those 9,000, 72 developed schizophrenia. Then what they wanted to do is to look to see who had siblings that did not also have schizophrenia. So that narrowed the study down to 32 people with schizophrenia with 25 of their siblings compared to 201 controls. And the reason this is important is because this is looking at when can we first start to see some changes in the brain? When can we first start to see some functional changes in their day-to-day life? And they could detect changes early as 7 years old. So on the graph here, lots of different tests at the bottom that you guys don't need to care about or know what they are. But the one where you can see the statistical difference, I think there might be a pointer on here. I don't want to turn it off. This is where the discrepancy is. I didn't put the error bars. But this task is called digit symbol coding. So in this task, it's a processing speed measure that the kid has to do, and they are discrepantly lower than their siblings and then age-matched peers. And this is well before they're ever diagnosed with schizophrenia, right? So what can we do? Why is this important? So information processing speed is not only a cognitive construct, but it incorporates into your functional skills in your day-to-day life. So it incorporates facial processing, right? Looking back there and see that someone's like snoring, or over there that someone's laughing. Okay, how can I change things up? Taking all that in. It impacts conversation. So when someone's asking you a question, you need processing speed skills to be able to respond to them in a timely manner versus kind of ruminating about it on your mind and then they're already off to the next thing. And then social cues. Those three things are all impacted in people with schizophrenia. Oftentimes, there's a huge literature. I see some of our pediatric neuropsychologists and our pediatric neuropsych fellow over there. There's actually a huge literature also looking at autism and schizophrenia because of these processing speed and difficulties with processing of facial information, social cues, things like that. Where's the overlap? And are there some neural underpinnings that are changing that could be overlapping and that we need to look at? Additionally, some early behavioral cues and changes that we might start to be able to look at is withdrawal, right? Are these kids or adolescents starting to withdraw because of the information processing speed difficulties? They just can't take it all in. It's too overwhelming. So instead, they're going to isolate. Patients will often say that, and the literature has looked at something called bottlenecked, right? When there's too much information coming in, it kind of gets that filter and not the right things get through. Additionally, patients often say that they feel a step behind, where you might be talking about something and they're still back here, right? You guys even saw that today, right, with Delante, where Dr. Cutler was on to the next question and he's going back to something else, or isn't quite there yet. So patients often describe feeling this way, which then leads them to feel really tired, fatigued, and just kind of pull away from things. Any questions about this really cool study? The other aspect of this study is the one that most people know has shown that IQ also starts to drop slightly, usually about 3 to 4 points before the onset of true psychotic symptoms. Another neurocognitive change that we can see is acquired dyslexia. So oftentimes patients with schizophrenia will have normal development early on, reading, writing, but we'll see a change with normal reading development around the time of the schizophrenia onset. And usually drops about 3 to 4 years before, the reading level where we'd expect them to be often drops about 3 to 4 years earlier than what we'd expect. So if they were reading at a 12th grade level, we then see them, they're reading at an 8th grade level. There's already that change in reading ability. But as you guys know, this disorder is complex, so what is causing this reading difficulty? It's probably a whole bunch of different things, likely some of this visual sensory impairment. So ocular motor changes. Dr. Sarakidi, our partner down at U of C, has done a lot of research looking at visual saccades and the changes that occur in patients with schizophrenia. So that could be impacting reading, as well as phonological processing, and then just that information processing speed. If you can't process it as quickly, you can't continue to read at the same pace as before. So as healthcare providers, it's really important to be vigilant about these changes, right? You might need to slow down in how you're asking questions of someone with schizophrenia, pausing after each short phrase, providing written information. So a written consent form will be very overwhelming to most people who are experiencing schizophrenia. So slow down, break it down, use visuals as much as you can. And then one hard part about this is rating forms, right? We all like to give our patients rating forms about their symptoms or how they're doing, new patient questionnaires. These patients, they'll plug through it. It takes them 2, 3, 4, 5 times as long as our other patients experiencing depression, anxiety to complete it because of these cognitive deficits. So really just continue to be mindful about that. If there is family support who can do some of that with them, that's great. But sometimes there's not that family support. Taking a step back, I didn't know if Dr. Cutler was going to talk about symptoms related to schizophrenia, things like that. Since this might be the first time for some of you guys hearing about schizophrenia, I wanted to cover some things that you should definitely know. Obviously, I'm not going to go through the DSM. But since I like measurement, I just wanted to point out a few tools that you might be able to use in your practice. So most people have probably heard of the positive and negative syndrome scale. It's cumbersome, it's long to complete, so most people don't do it. So there's been some other ones that Dr. Insel probably knows even better than I from work with NIMH, but the one that most people tend to be leaning towards and that research is now using is the clinical assessment interview for negative symptoms, or the CAIMS. It's shorter, it's 13 items, and it is more empirically valid and can be measured across time. So what are these negative symptoms that we're looking for? So one of the first ones that you guys will tend to see is avolition or apathy. So what does that mean? That lack of motivation, that inability to start or complete tasks. Importantly, these patients are not lazy or not trying. They're often labeled as not trying, or, we're asking them to do this, but they're not doing it. They're just not trying. Well, that is not the case. They're actually trying exceedingly hard to accomplish those tasks, but these are the symptoms that are getting in their way of doing it. Asociality, so lack of motivation to engage in social activities. It's not that they don't want to, it's hard to get motivated to do so. Anhedonia, lack of pleasure in doing things that they used to do. Blunted affect, it's something that you guys will see in patients with schizophrenia. As you know, it's their lack of ability to show outwardly and express emotions. So they may not be able to show on their face that they're feeling happy or sad the same way as before. They may not have a change of tone of voice. So oftentimes patients will speak really monotone. And then a change in their physical movements as well. And then alogia, really that poverty of speech, which, coming back to the neural models, is it really a poverty of speech, or is it because their information processing is so slowed that they can't get the information out in the same way that they want to? So those are all things that the research is looking at and targeting, because if these can be changed, then functional outcomes can hopefully improve, and ultimately that's the goal. Neurodevelopment. So I'm an adult neuropsychologist in full transparency, so neurodevelopmental models is not my area of expertise, but it's really important here because, again, it's where the field is going. So some people may disagree with this, but the bulk of the literature is saying that schizophrenia is a neurodevelopmental disorder. It is something that starts early on and is developed well before those adolescent and 20 years old. And we have support from this in our gene studies, and I'll talk about those in a minute. Schizophrenia is complex, so I'm not going to get through everything here in 45 quick minutes. And it's really complex to study because of the heterogeneity in the population. If we would have brought up 5 patients of Dr. Cutler's, no 2 would present exactly the same. There's also, the stress diathesis model where it wonders, are there things that are occurring that brings it out, that maybe it was underlying and we don't know if it was going to come out or not, but something else brought it out. So there's things like, the genetic components, obstetric complications have been looked at, lower premorbid intelligence, substance abuse has been looked at, SES, gender, all those things are being looked at. It's likely a complex interaction, which is why we haven't really found it yet, right? It's probably genetics, brain development, environmental factors, a whole bunch of different things. So this, again, is a whole nother lecture in and of itself. Fortunately, most of you guys here have probably heard Dr. Pablo Gajman speak. He's is here, our very own, at our research institute, and is the leader in the field in psychiatry, genomics, and schizophrenia. Additionally, we have our vice chair of research, Dr. Alan Sanders, back there in the back of the room, who also works on these psychiatric genetic studies. And that's why I'm not going to go in depth in them today, because I don't want to do that in front of Dr. Sanders, who's the expert in that. But we'll cover some of it. Importantly, Dr. Gajman's work, Dr. Sanders' work, they have founded really a Center for Psychiatric Genetics through U of C and North Shore. We have one of the largest NIMH grants that studies genetics of schizophrenia, specifically the GWAS study. So right, those large genome-wide association studies trying to figure out what is the complexity and what's going on. But very briefly, there are some really great twin studies showing consistently higher concordance in monozygotic twins, about 50%, than dizygotic twins, 17%. Some of the genetic studies do say that the heritability of schizophrenia can be up to 70%, 80%. So that's really high. So it's important that, once you know that someone in the family is diagnosed with schizophrenia, you start to watch for it and ask for it in other family members. There's lots of candidate genes that have been looked at that I just listed up there quickly, a lot that relate to chromosome 6. Dr. Sanders could talk all day about this. I'm not going to go too much into this, especially because one thing that we're having trouble is replicating a lot of these studies. And one of the hypotheses is that the difficulties with replication is because of the heterogeneity in the population that we're actually studying. This is a hard slide to see. So many of you guys know Dr. John Sweeney from U of C. He's a neuropsychologist, one of our colleagues. He passed away last year. I didn't think this was going to happen. Sorry. So Dr. John Sweeney at U of C is really one of the founders of the BSNP study. If you look at anything related to schizophrenia, you're going to find the BSNP study. And because of the heterogeneity, it's called Bipolar and Schizophrenia Network to look at intermediate phenotypes. We know that just looking at the DSM diagnosis is not getting us where we need to with the research. It doesn't classify people correctly. Even today, right, Delonte has schizoaffective disorder. In some studies of schizophrenia, he may or may not be included, right? So these are really, really interesting studies that look at key biological and behavioral measures linked to psychosis. This study itself had 1,872 participants diagnosed with either schizophrenia, schizoaffective disorder, or bipolar disorder with psychosis. because they're all quite similar, as you know. It also included their first-degree relatives and then healthy controls. And they threw everything at them. So neuropsych testing, especially looking at processing speed, executive functioning, memory tasks. They did eye tracking. Sarah Keaty worked really hard on all that. Looking at inhibition, brainwave responses, biomarkers, trying to figure out what can we do about this. And what's really interesting is those three different subtypes or biosubtypes emerged, cutting across clinical diagnoses. So how many of you guys have heard of the BSNP study? Okay, good. A few of you guys. So I won't go into too much detail, but you should definitely look it up because it's where the field's going. I wouldn't be surprised if the next DSM utilized some of this in there. But biosubtype 1, these are brain images, fMRI, looking at patients compared to their relatives on certain different types of tasks. And biotype 1 shows the most severely impaired patients, a construct that they call cognitive control. So that's really the patient's ability to flexibly exert control over their attention, processing speed, and they tend to be the most socially impaired. Biotype 2 is different, and they were more related to sensory motor reactivity. So their eye saccades were different. They had a harder time visually orienting to changes. And they had difficulty detecting and processing sensory stimuli coming at them. And then there's the biosubtype 3. You can tell that the brain looks not quite as bad as biosubtype 1, but worse than the controls who are their relatives. And these patients actually have normal cognitive control, generally normal, but they have pretty significant impairment with sensory motor activity and the lowest symptoms of lowest positive symptoms. So the least amount of hallucinations, delusions, and negative symptoms compared to the other cohorts. So if I were to guess, Delante would probably be biosubtype 3, right? Because he's pretty darn intact right now. So I just wanted to bring this up because it is where a lot of the research and time is going, is differentiating these subtypes. Getting back to a little bit more about the neurodevelopmental theory, some studies are showing as early as 12 years old, and that really there might be this prodrome period where we can detect changes with our tests and potentially do some interventions, right? Give some social skills groups, do some cognitive remediation to work on processing speed, to work on that acquired dyslexia that they're having, and to work really on those social changes. As you guys know from working with patients with schizophrenia, oftentimes, I don't know whose daily huddle's popping up. I don't have a mouse here, so please ignore it. Sometimes parents and teachers might say, my kid seems less interested in friends, or they're not participating at school like they used to. Oftentimes, as you guys know, patients with schizophrenia are often misdiagnosed with depression because of those withdrawal symptoms. They start to pull away because life is just too chaotic. So things to be thinking about. And then I can't get away without mentioning the largest grant right now for schizophrenia. I'm not sure if Dr. Insel's speaking about any research later, probably more about the book, but it's important to know that NIMH is funding studies related to this. And ProNet, look it up, it stands for Psychosis Risk Outcomes Network. This is the first worldwide collaborative effort on schizophrenia in that prodrome state, in the high-risk adolescents, in young adults, to develop, really aimed around that prodromal period. What can we do before it gets to that point? Miraculously, they got this off the ground in 2020, which is when there was a worldwide pandemic going on. And they're recruiting participants. It's going well, so keep your eye out for publications coming from Dr. Woods, Dr. Bearden, and Dr. Kane. Those are really the ones that are spearheading this huge study. But if you have patients you're seeing who you think might be in the prodromal phase, they're they're enrolling, so make sure you look at these clinical trials. I think this is exciting. It's kind of reminiscent of where the neurodegenerative field was years ago, right? Years ago, we knew about dementia, but we didn't know about mild cognitive impairment or the importance of intervening then with medications or activities and exercise, things like that. So I'm really hopeful that this is going to target biomarkers for patients who later go on to develop schizophrenia. So the most exciting part, case examples. So you're probably thinking, why is a neuropsychologist speaking about schizophrenia, right? It's not in the standard of care that APA says you diagnose a patient with schizophrenia, send them for neuropsych testing. Definitely not. But I would say that our top 2 referring reasons that we see patients with schizophrenia is, one, for diagnostic clarity, where you as a provider are saying, I don't know what's going on here. Please help me. Or number 2, our role is really to spend a full day with the patient and part of the day with their family or collateral to find out how their brain works in the real world, right? Pictures are great, blood work is great. That doesn't tell us how they function. So we like to look at their cognitive strengths and weaknesses, their social cognitive strengths and weaknesses, or emotional cognitive strengths and weaknesses, and then tell them what to do about it and what they might benefit from in terms of treatment planning, especially as it relates to supported employment. Most of our recommendations are saying they could tolerate working for 2 hours doing these sorts of tasks, and they can handle 5 pieces of information at a time. But if you give them 7 pieces of information, forget it. It's going to be too much, and you're going to get that bottleneck, and there will be no results. So I chose 2 different cases from my what I've seen so far here at North Shore Endeavor Health over the 14 years. I've seen many more than these. Again, given the heterogeneity, these 2 cases are pretty different. And especially were different from what I had seen in my training. So, much of my training was up at Great Lakes Naval Base, VA, and on the inpatient unit there. And I saw a lot of first episode, right? The guy's doing boot camp on the naval base, and it comes out. And I was shocked at how different each person was and how you really needed to tailor treatment to each different person, that no 2 people were alike. Well, this case example is really interesting. So he's a 20-year-old white male with 14 years of education who came to me for neurology with a referral question of ADHD. ADHD. I had a student on the case with me. They pulled an ADHD test battery, got the patient from the waiting room expecting 20-year-old with ADHD who's home on break from college. It also said cognitive changes related to ADHD. And please evaluate to clarify diagnosis and guide treatment. This patient had never seen a psychiatrist, psychologist, no mental health history. So then what comes next? Feel free to ask questions as I go along too. So I think behavioral observations were really important, and that's when I knew we were not dealing with ADHD right away. Patient arrived late, unaccompanied, even though we say, please bring someone with you. Conversational speech was remarkable for very long response latencies. You would ask a question, 30, 40 seconds later, you would get a response. And that's where, he had already seen a ton of doctors, primary care, things like that, but everybody had 15 minutes. He could barely even tell you what was going on in 15 minutes. Vague responses. So for example, I asked, where did you grow up? The area. Okay, what area did you grow up in? The North Shore. That's shortened. These were like 30 to 40 second pauses. Finally, he actually told me what town he grew up in. He was responsive to questioning, but very disorganized, paranoid thoughts, a lot of thoughts about, why am I here? What are you doing? Was very resistant to answer questions, when I asked why he was here or how he's doing. When I asked him why he was late to the appointment, why were you late to the appointment? Not an issue. Not an issue, you were an hour and a half late to the appointment. You're lucky I'm still seeing you, kid, right? I did not say that out loud. He was also very concerned about how long the appointment would take, right? I say, this is gonna be a full day evaluation. He said, well, I have an hour. What do you need to get to? Is there a reason you need to leave? We can reschedule. I'll be flexible with you. You might have stuff to do. He wouldn't sign the release of information. He eventually signed the consent form and agreed to consent to the evaluation. As we went along and rapport developed, eventually I said, it'd really be helpful, because I do compare you to other people your age and education, for me to know about your neurodevelopment, right? For me to start at the beginning. And since you can't answer those questions, I really need to talk to your mom or dad. Eventually, he consented for me to call his mom. Additionally, some of our normal tests, he couldn't even get through the instructions. There are time tasks for 2 minutes. He couldn't even start it. And it's not because he wasn't trying, right? It's those negative symptoms of amotivation. I asked him to talk to me about his favorite sport. He gave me 30 words in 2 minutes. Things like, I like watching it. There's a lot of different teams all over the country. There are many different jerseys. We don't do projective testing, but I thought it was interesting to bring that one in. Developmentally, pretty typical, raised by his parents, 2 younger siblings. Interestingly, though, he did have ADHD. He was diagnosed with it in the 3rd grade, had difficulty with math, but was on college on an athletic scholarship. So again, I'm seeing him, he's a sophomore in college. About a month ago, his girlfriend and coach contacted his parents about unusual behavior. His girlfriend said things like, he's stopped texting me. He doesn't want to seem to go out with me and my friends anymore. The coach said he's late for practice. This is something that has never happened before for him. And I'm seeing him now, he's been home from college for 2 weeks. Of note, normal pregnancy and delivery met developmental milestones on time, aside from the ADHD. So everything is plugging along really well in this kid's life until about a month ago. Medical history, sleeping well, exercising, obviously. He's on a collegiate sports team. Labs, EEG, the lumbar puncture, brain MRI, everything's unremarkable. They don't know what's going on with this kid. So again, they refer him to me for his ADHD's acting up. No medications. No mental health history. When asked about his mood, he said he's good, everything's fine, he does not understand why he's here. Denied suicidal ideation, hallucinations, delusions, trauma. Everything is denied. Finally, I got to call the mom. She also reported noticing that it's taking him longer to produce his speech and some odd behaviors that began about 2 months ago. So she said that some of his teammates would say he'd just be sitting in the locker room kind of just staring off at the wall. And they'd be like, come on, dude, we gotta go. And he's just sitting there. Everybody thought it was substance use. He was getting lots of drug workups at college, and once he got home, or stress from sport and exams, and just that his ADHD was acting up. And here's our interesting neuropsych data. So he has superior premorbid intellectual functioning. Very smart kid. Interestingly, despite what we often see with that acquired dyslexia, on a word reading task, the WATAR that estimates IQ, he has a standard score of 120, mean of 100. He showed intact executive control of motor abilities, problem solving, attention, and visual spatial ability. I was shocked. But impaired naming. On the Boston naming test, he only got 39 out of 60 words correct. On a verbal fluency task, one where I said, tell me as many words as you can, as fast as you can in a minute, to the letter F, go. He only produced 6 words in a minute over 3 different trials. Learning and memory and cognitive efficiency were all impaired. You can only imagine how much he was struggling at college and with his team. I gave him a PAI, which is a personality assessment inventory, to see if maybe he can't speak out loud to us about the difficulties he's having, but sometimes when you have the questions, they'll respond favorably to those. Unfortunately, it was an invalid profile because he was defensive and portraying himself in a positive light. But interestingly, I dug down a little bit more, even though it was invalid, and it was suggestive of him having disturbances in his thoughts and perceiving himself as having unsupportive family or friends, right? We could already start to see some of that paranoia and his concern coming out. On basic rating scales about attention, anxiety, depression, hopelessness, negative symptoms, everything was 0. Nothing's wrong. So for what I thought was going to be an ADHD case. We were seeing someone and diagnosing him for the first time with schizophrenia. Obviously, I did not do it there in the office that day because it takes us hours after he leaves to score the test up. I encouraged him to come back in with both of his parents present, and we discussed the results. And the initial diagnosis was rendered. To say that his parents were shocked was an understatement. They told me I was wrong, we needed to do more tests needed to be done, that we just hadn't figured it out yet. Fortunately, we have a great psychiatrist here, connect him to psychiatry for medication, and he's doing a lot better. We also connected them to local organizations. So what's really important is getting that community around them. So thresholds, you guys have probably heard of thresholds for community involvement and support groups. They helped with supportive employment. So supportive employment, we know, is one thing outside of medications that can be really helpful for people with schizophrenia. So this patient ended up working about 4 hours a week and was able to do that work with support. Additionally, assertive community treatment is what thresholds really holds. So assertive community treatment, unfortunately, has the same acronym. It's called ACT, which is the same as acceptance and commitment therapy, but they are different. So assertive community treatment is really a specialized model of treatment for SMI, where it's a multidisciplinary team providing care. Unfortunately, we don't have enough of those programs, right? But it's aimed at that pro-social engagement, getting people out, doing things, supporting them around doing that. CBT, cognitive behavioral therapy, and cognitive remediation have also been shown to be somewhat helpful too. So that's case one. Any questions? Okay, I'm gonna fly through this next one. Very different. 42-year-old Asian Indian male with 20 years of education, right-handed, was referred in by neurology due to concerns of worsening memory since his prior neuropsych eval 4 years ago. The difference in this case is that this patient had already been diagnosed with schizophrenia. They arrived on time with their father, was appropriately dressed. Completely contrary to the last patient, this person's conversational speech was so fast in rate and slurred, I could barely understand what he was saying. He was going a million miles a minute. Responsive to questioning, but very disorganized, often saying, well, they're watching me, I can't talk to you about that right now, let's talk about it in the other room when I do this and that and then do this. Cooperative, eye contact was really poor, right? Getting back to that processing speed, that social connection. He would often mutter under his breath to himself, and I'd say, I can't hear what you're saying, and well, I'm not talking to you. He often asked for repetition of directions. Again, another case where no one could have ever predicted this. No one did anything wrong, right? It just happens. So this patient, normal pregnancy and delivery, developmental milestones on time, attended college on an academic scholarship. Sorry, all you medical students in residence here. He developed schizophrenia while in residency. That's when the symptoms started. And I remember being in training, learning about all these symptoms, and then reflecting on myself like, oh my gosh, am I gonna get this? Am I doing that? Am I doing this? So please don't do that after this presentation. Before all these symptoms started, he enjoyed basketball, enjoyed talking to people, and was in residency as a doctor. He now gets 2 to 4 hours of sleep a night. Delonte mentioned some of the sleep difficulties he encountered early on. Is not exercising, labs are unremarkable. Those are some of the medications which I'm not going to go into because I'm not a psychiatrist and don't prescribe medications. But one medication was discontinued about a year ago. Again, he was diagnosed with paranoid schizophrenia, spends most of his time all day contacting lawyers, government agencies, trying to get to the bottom of why they're damaging his brain and killing him. He really does believe he will be dead soon and that they are working on killing his brain because it feels, much like Delonte mentioned, maple syrup, right? Things are not working the way that they should. Additionally, the hard part for me is he really has a distrust of doctors. He thinks we're all in on it. So getting him to buy into a full day of testing was not easy. I can't show too much of testing because it is copyrighted, things like that, in case you ever have to take it. But one thing that's out there on the internet is the Ray complex figure. You guys have probably seen this before. So we give that really complex figure to patients to copy so we can get an understanding about their visual spatial processing and their executive functioning. How do they organize information in their brain? And I just think it's helpful to see that this is how he organizes information in his brain, right? So that is what you see, that is what he sees. Kind of getting to Mr. Levert's point about the chaos that ensues, right? They're trying so hard. And one day it can be like this, the next day can be like that, but this is often what's going on. MoCA score, most of you guys know the Montreal Cognitive Assessment, brief mental status screener, 18 out of 30. Yet average IQ. Interestingly, compared to the other patient, processing speed was also impaired, but executive functioning was really impaired. So we do a card sorting task. He couldn't figure it out. We do a basic clock drawing. He couldn't draw a clock. Interesting, we did give the PAI as well, consistent with image management, trying to portray himself in a positive manner. But even with that, we could see the paranoid ideation and impulsivity. He came in with concern about memory. Memory is impaired, right? So during the feedback session, I couldn't argue with him. Yes, your memory is impaired. The good news is we had baseline testing. So compared to before, it hasn't worsened. So I could give him input saying, I know you feel like your memory is getting worse and like they're continuing to attack your brain and make it worse, but your memory is the same. So we know that some things are working. The medications are working, so keep on the medications. Some other things that hadn't been in place yet, despite a diagnosis for 12 years. This patient was not on disability. He had a 12-year diagnosis of schizophrenia. He did not have a power of attorney or guardian, which was really challenging when consenting him. So we helped his father assume full guardianship. We got the family more involved and understanding what was going on. So he started attending some support groups to occupy more of his time instead of being so focused on the positive symptoms of that they're attacking my brain. And importantly, we reinstated North Shore Connect access, which had previously been turned off, which I think so North Shore Connect access is how patients can message us. And it had previously been turned off because he would often send messages that were disorganized and didn't make sense. Well, of course that's going to happen. He has schizophrenia. But just because he has schizophrenia doesn't mean he shouldn't have an outlet to communicate with us, right? So we got that reinstated, and he could then again communicate and feel a little bit more connected with the doctors. As you saw with Dr. Cutler, that trust is so important, and to get that trust in the system. The other thing that happened with him eventually was we were able to get him connected with our speech therapist for some cognitive remediation. So not cognitive rehab, nothing's going to improve per se with the brain functioning, but getting some strategies around home to remind him to do other things, like eat, like avoid certain things, because like many of our patients, not only are they hit with the schizophrenia, then they're hit with the medical comorbidities, the cerebral vascular risk factors. So he was now diabetic, obese from not exercising, not doing anything. So getting him jump started with some of those things was really important again. Wow, right on time. I can't believe it. That went by fast. Any questions of those two cases or the studies about neurodevelopment? Yeah.
I have a question about the first versus the second. So the first one, if he had never had, like about the psychosis where he was hearing and seeing things, correct? Or been hospitalized?
Sure. So the question was, the first case, had he ever had any hallucinations, delusions, or psychiatric hospitalization? No. So, well, no hospitalization. It's very likely he was having hallucinations and delusions, but was not actively talking about them, right? And that's where that slowed processing speed, that thought blocking is coming in, and that he wasn't there yet. I mean, we caught it right pretty quickly, and that's really because he had a support network around him, right? His girlfriend, his coach, his team, his teachers were all saying, we're seeing a change. Unfortunately, no one thinks of schizophrenia, right? They thought of substance use. They thought of his ADHD. So yeah, good question. No mental health history at all.
I'm going to hold the rest of the questions.
So keep on pace with the break.
Yeah.
Thank you.
So our next presentation is on healing, our path from mental illness to mental health. For those of you who haven't gotten a copy of the book, this is the book, which is really remarkable. Dr. Tom Insel is the former head of the National Institute of Mental Health, and I had the pleasure of meeting him a couple years ago in San Francisco at a presentation where we were both presenting and came to be aware of the book. I think the book had literally just released like right around there. So really some thought-provoking words in the book, and I encourage all of you to get a copy. Tom is a physician, a psychiatrist who did his medical education at Boston University and then did his internship at Berkshire Medical Center and his residency at the Langley Porter Neuropsychiatric Institute, which is part of UC San Francisco in San Francisco. As I mentioned, he's the head of the National Institute of Mental Health for 12 years, and then went on to do some interesting things in the tech space, working at Google, Verily, and Mindstrong Health, and now working at Vanna Health, and I'm sure he'll talk a little bit more about all of that. So very excited to hear his presentation today and give us a unique perspective. So Dr. Tom Insel.
Well, thanks, Ramon. It's a real pleasure to be here, and I'm just super excited to be at a conference that's focused on this topic, not one that I think we talk enough about. I'll put it in the broad frame of serious mental illness because I think we're still struggling with some of the labels and the diagnostics. But from what you've heard already, it's a very interesting kind of introduction. I appreciate